Hello, everybody. It's a great pleasure being here. I'm Elena Gardella. I'm a neurologist and clinical neurophysiologist, and I dedicated the last 12 years of my work to the research and the phenotype and the clinical manifestation of SCN8A related disorders. It was a great pleasure to me to take part of the Delphi consensus as chairing the research group on the definition of the phenotypes and having the pleasure to collect the opinion of colleagues and realize that actually there is a consensus about the presence of at least 5 different phenotypes. And for further types, we intend clinical presentation of disease, clinical aspects, which are quite different and distinguishable from each other and reflect, different, in needing the needs to be addressed. We have the severe developmental epileptic encephalopathy, which is the most severe phenotype for SCN8A. We have a mild, moderate developmental and epileptic encephalopathy, where both epilepsy and development are less. A self-limiting infantile epilepsy, which is actually a very benign prognosis. And on the other side, we have formal generalized epilepsy and even cases without epilepsy at all. The key feature for these phenotypes actually are focused on the determination of the age, the seizure onset, and on the other side, the age of onset of developmental delay. The seizure types and all the other clinical features which are not related to epilepsy but contribute to the severity of the phenotype as well. Determining when children and patients can reach seizure freedom, if they do, and having also an overview of the prognosis for the no-seizure manifestation and phenotypes. So, what is the difference in the 5 phenotypes that we mentioned in terms of these key characteristics? What we know is that the severe phenotype of an earlier age at onset of epilepsy and generally also all the other clinical manifestation. There is a very early age at onset of seizure, and almost simultaneously in most of the cases before the age of 6 months, it can be evident some degrees of developmental delay. And achieving seizure freedom is quite difficult in this phenotype. For the mild, moderate epilepsy phenotype, we are an age at onset which is slightly higher. We have also the developmental delay starts in most of the cases later in life, sometimes after epilepsy onset, and the clinical feature associated with that are less pronounced and less invalidating for the subjects. Seizure freedom is possible in these cases. It's still an heterogeneous subgroup, but actually we can aim to achieve seizure freedom in this condition. And for the no-seizure manifestation, actually, is, as far as we know so far, there is a limited possibility to modulate, but still hope. Regarding to self-limiting infantile epilepsy, this is a very benign phenotype. Unfortunately, there is a little group, but actually the age of onset is still of epilepsy is still quite early, but the outcome is very good in terms of seizure control, in terms of cognitive and developmental outcome, and the comorbidities. We have the 4th phenotype is comprised generalized epilepsy. This is also a little group with very benign outcome normally in terms of epilepsy control. Unfortunately, the clinical features are not severe, but are difficult to control as well, and mainly consisting of mild cognitive impairment or autism spectrum disorder or movement disorder. The very last group, which is probably an underestimate, but is a little one, is about the clinical manifestation which are not associated with epilepsy. In this group, epilepsy doesn't appear. We just say either intellectual disability or movement disorder, or a combination of the two in some cases. We do not have, to our knowledge, we do not have that much room for modulating the outcome of this group, because we are not aware of treatment really effective on this group. This probably will be promising for the future. SGNA is very important to regulating that, but a variant, an alteration in the structure of the protein which is encoded for SGNA can give rise either to an excess of function of this channel, which is called gain of function, or for other mutation, for other variants, the effect can be the opposite. The channel can work less than expected, and a loss of function. So that means that we are dealing with imbalance of the sodium, which are possibly opposite. That means also that we need to be able to distinguish the gene finding that leading to a gain of function from the one that related to the loss of function, because also the treatment, as in is logically is intuitive. The treatment is opposite. For the gene file that giving rise to the gain of function, we need to block this excess of activity. For gene defects which are actually giving rise to the loss of function, we need to avoid to block them much, and probably find strategies to promote or increase the activity of these genes. We know now that actually these first three phenotypes that we are characterize, which are the severe DE, the mild moderate DE, and the self-limiting infantile epilepsy, all these three phenotypes are related to variant SGNA, which are giving rise to the gain of function. And this has an important implication for the treatment of this phenotype, which will be discussed later in the next talk. To the opposite, the generalized epilepsy and all the phenotype without epilepsy are in almost all the cases related to variant in SGNA that give rise to a loss of function. In these cases, sodium channel blockers, treatment that block the activity of this the sodium channel, has to be avoided.